I'm just going to talk about red eye. Don't be afraid of it. It can be taken care of. Just walked in, but don't walk out. Next slide. So anytime we see a red eye, think about a red eye, we're like, well, must be a pink eye, must be conjunctivitis. And yes, there's a lot of conjunctivitis out there. Most of it is viral conjunctivitis, which is flu of the eye, doesn't need any antibiotic treatment, just supportive treatment. Although it is very hard to kind of tell your patients that you're not going to give them drops. They're going to be unhappy. Allergic conjunctivitis, you can get that from the history, lots of eye rubbing, allergic shiner. Next slide, please. Looks a lot more diffuse, not as angry. And believe it or not, bacterial red eye, bacterial conjunctivitis is quite rare. So if you truly believe it's bacterial, you should refer it. Generally responds well to antibiotics. I put up hepatic eye disease. You probably won't see it primarily. This slide is just there because I just love how pretty it is. It's the dendrite. It's what shows up on the eye when you have hepatic eye disease. But I'm sure a lot of you see shingles. Especially if there are lesions around the eye, but more particularly at the tip of the nose, there is a high chance of corneal involvement. Doesn't mean it's a super emergency. You can treat it, start the patients on antivirals, and then refer them to your friendly ophthalmologist within the next 24 to 48 hours to next slide to check for any corneal involvement. Next slide. And then this really freaks everybody out. It's a bright red eye. It's just a broken conjunctival vessel. Patients get freaked out, but they don't have any symptoms. So either they saw it in the mirror or someone pointed it out to, hey, you have a red eye, what's going on? It's mostly related to Valsalva. So there would be a history of either heavy lifting, vomiting, straining, coughing, supportive treatment. I assure my patients and tell them it may get a little worse before it gets better, but not a whole lot we can do. Stay away from the red eye removing drops. But if you do see a subconjunctival hemorrhage on the right, which is covering most of the white of the eye, that you probably want to refer it. So continuing it on, in my practice as an ophthalmologist, this is the most common cause of red eye that I see. It's dry eyes. In today's day and age, we're on screens all the time. We're working in either air conditioned or highly dry, warm environments. There's a lot of dry eye, and it causes a lot of symptoms. The first line therapy is over-the-counter, tears, compresses, but we've actually come a long way in treating dry eyes. So we have really, really good therapies. Patients don't really have to suffer with it, and it is quite annoying. Next slide. And there's a lot of over-the-counter stuff available. I put that slide up there just to kind of show that's moderate dry eyes. That's a lot of tiny little abrasions on the cornea. It looks like sandpaper. It feels like sandpaper, so patients are quite uncomfortable. Anytime you see a contact lens related patient, I would refer them. There's a lot of bad things that happen from contact lenses. Patients don't have the best contact lens hygiene. They sleep in them, they shower in them, and lots of bacteria and other organisms can grow there. And then, not to forget, if you see any patients, next slide, who have red eye in conjunction with rheumatologic disease, it's probably a good idea to have them established with an ophthalmologist in case there's something else going on. I just put this out there to complete the presentation. Chemical trauma, you'll have a good history about that, but I always, if that ever happens, I always ask the patients to bring what they think they got in their eye, because believe it or not, alkaline materials are a lot worse than acid. Acid rinses off easily, gets out of the eye, but alkaline, the cornea tends to absorb it and can cause damage for many hours after. So rinse, 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 and then refer. Mechanical trauma, we see this a lot. Next slide, please. Finger to the eye, tree branch to the eye. If you want to check for an abrasion, actually relatively simple to do with a fluorescein strip, and you can see a large abrasion there. This is very painful. Patients would be crying. crying, they can't keep their eyes open, they can't see. Unfortunately, not a whole lot we can do for pain control. Even opioids don't really work. They'll help them pass out, but won't help with pain. So I tell my patients to kind of take it easy, give them prescribed ointment, give your eyes a rest. It will be a lot better in 24 hours. I patch a lot of patients when they have large abrasions. Next slide. And again, remember, do not prescribe steroid drops or topical analgesics to these patients just because they're complaining. Next slide, please. So in conclusion, most of the red eyes are self-limited and just need supportive treatment. Anybody with any kind of rheumatologic disease in red eye should probably have an ophthalmologist. Dry eyes need chronic treatment, and we do have a lot of good treatment for that. And please don't prescribe steroid drops unless you're sure what the diagnosis is. And I just put this slide up there because, believe it or not, that's all you need to really diagnose and differentiate between a lot of these red eyes in your office. I'm just curious if people have fluorescein strips in their office. Does anybody? My vet has it. So I was